This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Rick Harvey. Welcome, Rick. Thank you for being with us tonight. Yeah, we have a lot of different kinds of physicians that come along and to talk to us about one thing or another. And you are a cardiac surgeon, is that correct?
That's correct.
Is that a tough thing to do, to be a heart surgeon? I'll just ask that question.
There's some work involved.
What does that involve exactly? How long does that take?
Well, like yourself, it's 4 years of medical school.
Yes.
5 years of general surgery, and then 2 or 3 years of cardiac surgery after that.
So you've climbed quite a tree here, have you not?
It's been a long ride.
It's been a long trip, and now let's see if am I getting this right? You were considering a career in divinity, or is that correct? How you were wanting to be a minister initially? Or
when I graduated from undergraduate school, I went to seminary, and while I was there, I actually became sick, very sick, and was in the hospital.
Really?
And it was during that process that kind of the wheel got turning, and so I went back and did some pre-med work and went to medical school.
Well, good for you. I mean, there's quite a similarity, really, in many ways between the work that we're involved with, and humans in different situations. And there's a lot of similarities. Well, I know you do a lot of different kinds of heart operations, but you have tonight, you brought along half of an artificial heart, as you said. I don't know if the camera can show you. Maybe you can pick it up.
Sure.
We can show you what this is. Half of an artificial heart, which is pretty interesting. And what's going on is right now in Macon, Georgia, you're putting this in people, and this is a ventricular assist device. Is that the turn of phrase?
Correct.
And why don't you just tell us? It looks pretty impressive. Why don't you just discuss what you have in your hands?
Sure. What's in my hand is 2 batteries. They have a life of about 10 to 12 hours. There's a controller which has some alarms and things that patients have to learn about. This particular line right here comes out the abdominal wall. So from this point this way, all of this is external, outside the patient. From about this point in, all of this is internal. Now, this is a mock-up, so normally there wouldn't be a tube like this inside of a patient, but this is the device itself right here. This has what is the equivalent, it's a little bit more sophisticated, but like a boat propeller.
Yes.
That spins and turns, in humans' case, blood. Right now it's turning water with a little air mixed in it so you can see the movement. And this can generate up to 10 liters of blood flow per minute.
That's a lot, yes.
It's a lot. And this is used in patients whose heart failure becomes so advanced that they really have their lifespan has become very limited. And so these patients are very sick, and this device can actually give them their life back in an amazing way.
So this is I'm remembering the development of artificial hearts. Let's see, the Javik 7 or 8. And now this is not a full artificial heart.
It's not.
And there are problems with a full artificial heart. It really hasn't taken off, as one could say that. I mean,
that's correct.
And I think some of the problems are smashing those red cells up. Any comments about that? Or what are some difficulties we have here that the public might need to be aware of?
Well, what makes this device unique, all the attempts at heart support prior to this device coming along, which is now FDA approved, there's only one FDA approved device right now for what's called destination therapy, which is a patient receiving one of these devices that's not a candidate for a transplant later. The problems were associated with this component, or the VAD itself. They're all attempted to be what's called pulsatile flow, or have a systolic and diastolic blood pressure. That required a lot of moving parts.
Yes.
It beat up blood cells.
Yes.
Clots formed easily.
Yes.
So there were a lot of strokes and complications associated with this. This device won the battle because there's only really one moving part in this device. and so it doesn't beat up the red cells. It can clot, but it's very rare.
Yes.
Strokes are very low.
Yes.
And what makes this unique, though, is it's continuous flow.
Yes.
So a patient who has one of these devices actually doesn't have a standard blood pressure like we have known all of our lives. They only have a single number called a mean arterial pressure.
So it would be like a Martian that showed up, and there's a hum. Wait a second, this person must be a Martian.
Right. You grab the wrist.
There's no pull away. We must have a Martian with us. Yes.
So there's a lot of education involved. You have to learn how to check your blood pressure. You have to learn how to manage this device. But you take people who barely can do anything during the day, and in the right circumstances with the right patient, they're patients that run 10K races with these devices.
Well, it's a pretty extraordinary thing to have in this part of the world. Now, is this there's a lot of cutting edge research. There's a lot of progress being made, and people with bad hearts, they're candidates for heart replacement, heart transplant. And this is, at least initially, envisioned as a support mechanism before their transplant.
That was its inception. Now it has, as of January 2010, this device has become approved for, the term is called destination therapy.
Yes.
It's for a patient who's not going to be a candidate for a heart transplant. They will receive this device, and that's what they will live the rest of their life with.
Now, let's see, I think Vice President Cheney, who I think the public follows along a little bit, he had all sorts of trouble with his heart, and he had this put in prior to his heart transplant. Is that correct?
That's correct. And it was this very device, a HeartMate 2.
Yes.
And I believe he kept it about a year and then received a transplant.
Can people be pretty comfortable with this? I mean, is it painful to have this in? I mean,
Not painful.
No pain and.
Well, the beauty, to go back a little bit on this, there are basically 5 million people in the United States today that have heart failure.
Yes.
Of that, there is a large percentage that have what's called advanced heart failure. That means they are in stage 3B or stage 4 heart failure, which means you're doing good to be able to get up out of bed and eat a meal and get dressed that day. And that's your day.
Yes.
Now, that sum of patients cost our healthcare system $35 billion a year.
Yes.
Its mortality rate is second only with optimal medical therapy.
Yes.
The only thing that will take you out of this world sooner is pancreatic cancer.
Yes.
So this is the number 2 killer.
Yes.
The survival of 1 year, 1 year survival with advanced heart failure is approximately 25%.
Yes. Yes.
These devices take those patients, and their survival now is approaching in the mid-80s for 1 year. Transplants is in that area now for 1 year. And not only does the patient stay alive, but the patient has a functional improvement in their lifestyle. 80% of patients who receive this device become New York Heart Class 1 or 2. That means they have no or minimal symptoms. So it's a dramatic change. Not only do they not die from heart failure, but they have their life back. They can do things.
Yes.
So what discomfort there is learning how to live with a cord.
Yes.
And that probably will not be around much longer. There are totally subcutaneous devices now. They'll probably be out in the next several years.
Now, it's one could imagine in the future this lends itself to doing lots of people receiving this.
Correct.
Heart transplants that's a real hard problem to get a heart.
Correct.
What are some problems of people that might want a heart transplant? I mean, there are lots of problems.
Correct. Underlying medical conditions can prevent you from it. If you have uncontrolled diabetes, if your body size is too large, you can't receive a heart transplant. If you have pulmonary hypertension, you can't receive a heart transplant. Blood types, very limiting. And for 15 years, the number has been flat, 2,400 heart transplants done a year in the United States. There are roughly 400,000 people that would be candidates for this device.
So really, this is a pretty extraordinary machine we see here that may really help a lot of American citizens out there.
Correct.
And we occasionally talk about the American healthcare system. I take it this is not taking place in France right now. Is that correct? Or maybe it is.
It's taking place in other countries.
Other countries, but we're really, as far as the ability to do things and make things work, the American healthcare system has got the ability, and there are lots of cardiac surgeons out there that we pay a lot of attention to this, and our system is set to use this.
Yeah, and there's not a lot of things that come along in healthcare that in addition to giving your life back, actually make your cost to the system cheaper.
Now, there are not too many places that do this. I mean, you're doing it in Macon, and where else do we have this technology around?
Traditionally, this technology has been limited to programs that only do heart transplantation. Yes. And over the last 2 years, there has been a movement outside of transplant centers. When you start thinking about heart transplantation, you're going to limit yourself to urban centers that
Yes.
are generally academic.
Yes.
And so patients would have to, someone lives in this part of the state, they would have to go to Atlanta.
Yes.
And since there's such demand, the movement has been, since destination
Yes.
care became approved,
Yes.
to move toward community hospitals that don't do transplantation.
Yes.
And so the access is greater. Right now in Georgia, there statistically are about 2,000 people that would be a candidate to have
Yes.
this device.
Yes.
Last year there was 125 or so put in this state.
Yes.
So you can see that there's a wide gap between availability and needs.
Yeah, one of the things that I think we're encountering in our healthcare system is the money to pay for this. So this is a pretty expensive thing to put in. May I ask how much this costs and what is?
This cost roughly $87,000.
Yes.
A patient with class 4 heart failure, the last 6 months of their lives cost the system $80-something
Yes.
thousand dollars. So their overall cost to the U.S. year in and year out is $35 billion.
Now, one of the things that I think people are concerned about, at least watching, is because we have a new healthcare system with the government having extraordinary power over who gets what. I mean, is the government going to allow this to be done? Is it going to be too expensive? Or are we going to have some? I think the way things have worked in the past is if we could come up with a good advance that helped people, generally there'd be a way to get it accomplished.
Correct.
And that may no longer be the case. Is the government going to allow this to be used?
Well, right now, much like renal transplantation was and has been, it's actually cheaper for someone, for the cost,
Yes.
for someone to have a kidney transplant than it is to stay chronically on dialysis.
Yes.
So when a patient reaches a certain level of heart failure,
Yes.
it's actually cheaper in the long run to have this device than it is to pay for continual health care. That's the reason it's been approved for destination therapy.
Well, just to keep talking about it, it seems reasonable to do it, but that might not stop the government from not allowing it to be used. I mean, right now they're saying it's okay to do it, and we have enough
Oh, sure.
interchange with
Sure.
them to say, look, this is a good thing. We're not getting rationing problems with this, right?
That's correct, but I do suspect that if all the people that need this device are reached, then there might be some real concerns.
Yes. And is this technically difficult to put in? I mean, how would you approach this? You're going to just open them up?
Well, of cardiac surgery, surgical operations that we do in cardiac surgery, this is not the most difficult, but it's not far from it. And it is a demanding operation to do, but more importantly, the patients that we do this surgery on are so sick.
Yes.
Caring for them is
Yes.
extremely demanding.
So they wouldn't get this unless they're really a
That's correct.
tremendous number of medical difficulties. And the postoperative care is very vexing, I think.
Even for these patients, there's a fairly lengthy preoperative preparation to
Yes.
have the surgery. So
Yes.
it's a very complex kind of milieu that you have to.
Yes. When these people that have their systolic ejection fractions or some terrible number, 6 or something, I'll pick a bad number. Maybe
Right.
that's
That's
what
a
it
bad
is.
one. Yeah.
Is it a 6? Is a bad one.
That's a bad
But I mean, they have some terrible numbers, and it's really gratifying to see this put in. Life changes, does it not, if they get this done successfully?
The last patient that we did here in Macon is a 35-year-old patient who has 5 children.
Yes.
He is a former deputy sheriff, and I was talking to him about this device prior to putting it in, and he was asking me some of the things he might be able to do after he had this device. Now, he has pretty much been confined to, he can get up and he can walk some, but if he wants to really go somewhere, he has to go in a wheelchair.
Yes. Yes.
Because he just gets so short of breath.
Yes.
And as we were discussing this, I said, well, you'll be able to play with your kids again.
Yes. Right.
He couldn't, that had never entered his mind.
Well.
And so that young, he should be able to do a normal day's work if he wants
Yes.
to.
Yes. Well, that's a great story, and you mentioned that it might even get a little better using batteries. We have to have an external power source here, is that correct?
Well, there are devices right now that are in the lab that are that do not have external batteries, that do not have external drive lines, and so they're powered. Some of them are powered by Wi-Fi. So as long as you're near a Wi-Fi station, your battery, which is internal, is getting charged.
Yes.
And so that'll probably be within the next 5 to 10 years.
Yes. So it sounds pretty exciting. Now, are the problems that might occur with this infection or stroke or clots? What are some issues that could happen?
The number one problem with this device, because there is a apparatus leaving your body, is infection.
Yes.
And because this is prosthetic, the last thing you can afford is for this to get infected.
Sure.
So these are called driveline infections, and that's when the site where this exits the body becomes reddened and inflamed, and they're treated very aggressively. It's rare that these anymore lead to an infection of the device.
Yes.
It has to do with some of the technical changes we've used in planning the devices. All of these patients will have what's called von Willebrand's disease, which means their platelet aggregation is not normal. Something about continuous flow that they haven't elucidated what exactly that is leads to them having von Willebrand's disease, so they have a little bit higher propensity to bleed. Heart failure patients have a little higher propensity to bleed anyway because they generally have liver failure.
Yes.
So there is a risk of stroke, but it's less than the risk of stroke with AFib.
Yes.
So all of the things that were such a problem with artificial support systems in the past, the hurdles are being overcome every day. There are still a lot of advances. There's actually Houston now has, once the Transplant Society and the Failure Society got comfortable with continuous flow, they now have a device like this that has 2 pumping chambers and can be a total artificial heart. And they are putting those in laboratory investigations now and have put that in a human being now. So we're not far away from that as well.
Has there been much trouble with the FDA? We occasionally hear reports they're holding progress back, or you have any comments about that? Or they've been pretty righteous about this, or
I think at this point they've been fairly righteous because the cost is so high. And so the attitude is whatever we can do to lower cost. I think if a lot of people start living a lot longer with devices like this we may see changes.
Yes. Well, is there a waiting list for people to do this, or it just?
Fortunately, because these can sit on a shelf, there's not a waiting list.
Yes.
So it's a matter of a patient getting referred to an advanced heart failure system and having the opportunity to be evaluated to see if they're a candidate for this.
And the way the government pays for this, I mean, I think the medical center's not receiving money yet, or what is the story about that?
Well, there's a process you have to go through to become a JCO certified center, Joint Commission certified center, and you have to implant them in your center before you can begin the process.
Yes.
So there is a period of time where Medicare reimbursement is not available until you get JCO certified.
So this was, in a way, doing this. The medical center took a pretty righteous step, if I could say that.
This requires a huge institutional support system. It requires a relationship with a transplant center.
Yes.
There's a lot of requirements that go into this, and the medical center really had to take a leap of faith doing this. And I can say that the hospital was very supportive of it because there's so many people in Middle Georgia that have heart failure. It's a big problem.
Yes. The heart failure that we see out there, you have any comments about that? Will preventive care help this, or stay away from pork chops? What's some advice to
it depends on the
watch
cause.
that whole heart health here?
Right. It depends on the cause. The most common cause is hypertension and/or coronary disease, or what's called ischemic heart failure. But there are a lot of other causes for which there is no medical viral cardiomyopathies.
Yes.
Patient has a virus which leads to their heart failing. There's not not something you can do for that. Postpartum cardiomyopathies, sometimes after childbirth, young females will develop cardiomyopathies and have to either have one of these devices or go to transplant. So there are a lot of reasons people develop heart failure.
One thing to do is I guess it's a patient responsibility issue before you get to this stage. There's some things that you can't help, but a lot are diet, exercise, and take your medicine and watch out for your blood pressure.
Correct.
And I think both of us see huge numbers of people that don't take their hypertensive medicine. Is that a fair statement?
Yeah. Having a primary care doctor, taking your medicines, not smoking, diet and exercise, keeping your cholesterol under control,
Yes.
all of those things are very key to not developing at some point what could be ischemic heart failure later in life.
And so prevention is a big thing. I mean, and statins are a useful adjunct to. Do you want to comment on statins?
You know, statins in the world of cardiac surgery, we are just now beginning to use statins because traditionally that has been prescribed by primary care doctors and cardiologists, but it's become so evident that statins are key to reducing ischemic heart disease that it's a part of one of our guidelines is all of our patients have to be discharged with a statin. For years, the number one killer has always been cardiovascular disease, and it's been continually on the rise. In the last few years, we've seen a plateau and a decline in cardiovascular disease. That corresponds with the 20 years that statins have been available. And it's not just lowering the cholesterol. Patients need to be aware that there are other components to statin drugs that are helpful in prevention, and that has to do with inflammation. Statins reduce inflammation, and coronary disease, atherosclerotic disease, is an inflammatory response. So the drugs have finally had an impact on the prevalence of cardiovascular disease in this country.
That's a big deal. We see less strokes, so that's a good step forward. Well, do you have any predictions of where this technology is going? I mean, we're going to have an artificial man out there. I mean, it's pretty impressive, isn't it? Any comments?
I do see a total artificial heart coming again. And this one will be made with a continuous flow device like this, so there won't be the problems that were there with the last generation.
And well, that would be a pretty impressive thing too. Well, what about exercise with this? I mean, we discussed. I guess the way the heart traditionally works is it responds to stress requirements, and it varies its cardiac output depending on your. Right now, we're kind of just sitting here, and our cardiac output doesn't have to be that great, but other situations it has to.
That's correct. There are devices that are in investigation right now that are continuous flow devices that will respond to physiologic stresses. They're a long ways from being out there for patient use. But currently, because the problem has been a low flow state in these patients for so long, having high flow, the body's response to that, it learns to engage the blood return to the heart to adjust that. And so it also can use the vasoconstrictive neurohormonal information throughout the body that can change your vasodilation or constriction. So the body still has a response. What it doesn't have is an increased heart rate or an increased flow. But the flow is better than you need.
Yes.
So you have reserve. And right now, that's more than adequate to give a patient a very productive life.
So this is a rather clever idea, continuous flow here. Who came up with that? I mean, that's a pretty good idea.
There were so many different people involved. I wouldn't want to even say one name, but there were several people that were doing this rendition during the time of the Jarvix and the pulsatile devices, but no one felt comfortable with continuous flow.
Yes.
And as they started failing, these started becoming more and more prevalent. A lot of the temporary assist devices that we used for years had continuous flow.
Yes.
Patients started doing better with those.
Yes.
So getting away from this idea of having to have a systolic and a diastolic blood pressure became easier. And then the investigation led to...
So just in talking about the way medical progress happens, there's some, I assume this was put in animals. There were some animal experiments, is that correct, on this? So there were lots of animals used.
That's correct.
That you could say sacrificed themselves for our species, and they were appropriately treated. But medical research depends on that. And if somebody stops the use of animals in medical research, we don't want to. We obviously are caring people. We don't want to.
Right.
But there's an ethical issue there where you can save this person's life, the 35-year-old gentleman with the 5 children. That's something that has to be weighed in these equations.
Absolutely.
And we really need access to experimental animals. Is that correct?
That is very correct. In the field of cardiac surgery, animal experimentation has been the key to almost everything we've done.
Yes. Now, I think pigs, I don't know if you use pigs, but I think we often, with the
Pigs,
animal,
we use
cows and
right
pigs.
now, these devices, the total artificial hearts are in cattle, and they've been alive with these devices in for quite some time now, actually.
And so this is the kind of thing the public needs to allow to continue. We don't want our research that help people so enormously to be terminated in ethically incorrect fashion. Is that fair to say?
That's very fair, and I think there's an ethical way to do it, to treat animals with responsibility, but at the same time, these advances will not be made if we don't use animal experimentation.
Yes, yes. Well, we have a lot of things out there that are coming down the pike. How many do you anticipate doing next year, if I could say this? What's your guess on this?
When we initially started the idea of this program, we expected to do 4 in the first year.
Yes.
We're already there in the first 2 months, and so the failure is so prevalent in Middle Georgia, I would not be surprised in the first year of this program if we don't do somewhere between 20 and 30.
It's a big number, isn't it?
It is. And the biggest programs in the country do in the range of 50 to 60. So, and I'm sure that will grow.
Do you have the resources behind you to do this? Do you think you're adequately people to help you? You have a team, and that's an important thing. Is getting your team together. And
fortunately, as a part of this, though, the process and the certification to do this requires that you have those pieces in place.
Yes.
And so we have the team, and the team will have to grow as we grow. And there are different roles. There's something called a VAD coordinator, or a ventricular assist device coordinator, that is a 24/7 job. You need one for every 12 to 15 patients that have these devices in, so we'll have to grow as those number of patients grow.
Well, Rick, it's been great having you here tonight. Keep up the good work. I'm proud of what you're doing here. You're doing great.
Thank you.
Congratulations.
Thank you.
Good story here.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.